السلام عليكم ورحمة الله وبركاته. النهاردة إن شاء الله هنتكلم عن موضوع Thyroid Eye Disease أو Graves of Ophthalmopathy. Definition: Thyroid eye disease is an autoimmune inflammation of the soft tissues of the orbit. It is caused by the activation of orbital fibroblasts by autoantibodies against thyroid receptors. Thyroid eye disease is associated with hyperthyroidism in almost 90% of the patients. 10% of patients may have either a normal functioning thyroid gland or underfunctioning of the thyroid gland. It is the most important extrathyroidal manifestation of autoimmune thyroid diseases. Women are more affected than men. Clinical picture: there may be systemic manifestations related to thyrotoxicosis, such as tachycardia, palpitation, and tremors. Ocular manifestations are divided into, first of all, soft tissue involvement, which includes periorbital and lid swelling, conjunctival hyperemia, which is characteristically intense and outlining the insertions of the recti muscles, chemosis, and superior limbic keratoconjunctivitis. This slide demonstrates the most characteristic soft tissue signs, such as periorbital and lid swelling, conjunctival hyperemia, chemosis, and superior limbic keratoconjunctivitis. Second, lid retraction in the primary gaze, also known as the Dalrymple sign. It is present in 90% of the patients. It is caused by overaction of the molar muscle. Eyelid retraction may often be accompanied by a lateral flare. This appearance is almost pathognomonic for thyroid eye disease. Third, axial purpurtosis. It is present in 60% of the patients. It is caused by the forward displacement of the eye by the enlarged extraocular muscles and may lead to corneal exposure. It may be unilateral or bilateral. Fourth, restrictive extraocular myopathy. It is present in 40% of the patients. It causes diplopia and it can be detected by positive force reduction test. The inferior rectus is the most commonly involved muscle, followed by the medial rectus, then the superior rectus muscle. Fifth, optic neuropathy. It is present in 5% of the patients. It causes an early defective color vision, then later visual impairment. It is caused by the compression of the optic nerve or its blood supply at the orbital apex, either by the enlarged extraocular muscles or the orbital content. Other ocular signs in thyroid eye disease include von Graeff's sign, which is upper eyelid lag on downward gaze, Stellwag's sign, which is infrequent blinking, and Mobius sign, which is weakness of convergence. Orbital imaging shows muscle belly enlargement with a characteristic tendon sparing. This slide shows characteristic signs and CT findings in patients with thyroid eye disease. The first photo shows bilateral proptosis with marked lid retraction. This is the characteristic von Graeff's sign. These are axial and coronal views of a patient with thyroid eye disease showing characteristic enlarged muscle belly with tendon sparing. Treatment of thyroid eye disease. First of all, the patient should stop smoking, as smoking increases the risk and severity of the disease. Medical treatment involves control of the thyroid dysfunction, ocular lubricants for exposure of the cornea and conjunctiva, systemic steroids. It is indicated in cases of optic neuropathy and rapid progressive proptosis, prism spectacles for diplopia. Orbital radiation can be used to decrease inflammation. Surgical treatment. It should begin 6 to 12 months after stabilization of the case. Surgery is performed in a stepwise fashion with orbital decompression first, then strabismus, and then finally lid surgery. First of all, the orbital decompression. The indications are optic neuropathy that fails to respond to steroids and orbital radiation, severe corneal exposure that is refractory to medical treatment, or severe disfiguring proptosis. Bismuth surgery involves recession of the affected muscle, never do resection. Lid surgery, if there is upper lid retraction, we do malarectomy and levator recession. If there is lower lid retraction, we do recession of the lower lid retractors and use of hard palate or mucosal graft. Differential diagnosis is from other causes of proptosis in adults. Most common causes are non-specific orbital inflammatory syndrome, also known as idiopathic orbital inflammatory disease or orbital pseudotumor, orbital myositis, indirect carotid cavernous fistula, optic nerve tumors such as optic nerve sheath meningioma and optic nerve glioma. Less common causes are extraocular muscle metastasis, venous granulomatosis, sarcoidosis, amyloidosis, and collagen vascular diseases. Idiopathic orbital inflammatory disease. This is a non-neoplastic, non-infectious orbital lesion. It involves any or all soft tissue components of the orbit. Clinical presentation is usually with a unilateral and abrupt painful onset. CT shows ill-defined orbital opacification with loss of definition of the contents. This picture illustrates a patient with idiopathic orbital inflammatory disease. It is characteristically unilateral with periorbital swelling and chemosis, proptosis, and ophthalmoplegia. Clinical course and treatment of idiopathic orbital inflammatory disease. Early, with spontaneous remission and without any sequelae, we do not offer any treatment. If there is prolonged intermittent activity with eventual remission, treatment options include steroids, radiotherapy, and cytotoxic drugs. Severe prolonged activity can cause frozen orbit. This picture illustrates a long-standing case with frozen orbit. Orbital myositis. This is a non-specific inflammation of one or more of the extraocular muscles. Presentation is with sudden onset of pain and diplopia on ocular movement. Orbital imaging shows diffuse enlargement of the muscle with tendon involvement. Clinical course is usually short and is treated with non-steroidal anti-inflammatory drugs. This is an axial CT scan of a patient with orbital myositis, demonstrating fusiform enlargement of the lateral rectus muscle. Indirect carotid cavernous fistula. This is an indirect communication between meningeal branches of internal and external carotids and cavernous sinus. It is also known as low flow shunt. Clinical presentation is with dilated episcleral vessels, which are not confined to the recti, chemosis, raised IOP with wide pulsations. Orbital imaging shows diffuse enlargement of the extraocular muscles and distension of the superior ophthalmic vein. This picture illustrates a patient with indirect carotid cavernous fistula. Picture A shows dilated episcleral vessels with chemosis. Picture B shows the dilated superior ophthalmic vein. Optic nerve sheath meningioma. It arises from meningothelial cells of the arachnoid villi surrounding the optic nerve. It typically affects middle-aged females. Clinical presentation is with gradual unilateral visual impairment. Transient obscurations of vision may be the presenting symptom. Signs: there is a classical triad of visual loss, optic atrophy, and opticociliary shunt vessels. The sequence of involvement is as follows: optic nerve dysfunction and chronic disc swelling, followed by atrophy. Opticociliary collaterals. These are enlarged pre-existing peripapillary capillaries, which divert blood from the central retinal venous circulation to the peripapillary choroidal circulation when there is obstruction of the normal drainage channels. Proptosis. It is caused by intracorneal spread and usually develops after the onset of visual loss. There may be restrictive motility defects, particularly in the upgaze, occurring because the tumor may splint the optic nerve. CT shows characteristic thickening and calcification of the optic nerve. This slide illustrates a patient with optic nerve meningioma. Picture A shows defective elevation of the right eye, while picture B is an axial CT illustrating the tumor as thickening and calcification of the optic nerve. Optic nerve glioma. It is a slow-growing pilocytic astrocytoma which typically affects children. Approximately 30% of patients have associated neurofibromatosis type 1, and in these patients the prognosis is better. It typically affects children in the first decade of life. Presentation is frequently with slowly increasing painless proptosis and visual impairment. Signs: proptosis is often non-axial with temporal or inferior dystopia. The optic nerve head initially is swollen and then becomes atrophic. Opticociliary, collaterals, and central retinal vein occlusion are occasionally seen. Intracranial spread to the chiasma and the hypothalamus may also develop. CT shows an fusiform enlargement of the optic nerve. In patients with associated NF1, the enlarged optic nerve has a clear-cut margin produced by the intact dural sheath. This picture illustrates a patient with optic nerve glioma. Picture A shows that the patient has a down and out dystopia in the right eye. Picture B shows in the axial CT of the patient showing a fusiform enlargement of the optic nerve. Thank you very much for your attention.